Oh, good morning, everybody, and welcome to the Greenblatt Award session, which is the first time that we have had to do this virtually, but still I'm delighted to see so many people are actually logging in to join us. So the Robert Greenblatt Award is a Young Investigator Award where 6 candidates are shortlisted to present at the International Menopause Society Congress, and will be presenting in this session. For those who don't know, Robert Greenblatt was the first president of the IMS in 1978, and was an endocrinologist who was one of the first to show that estrogen suppressed hot flushes, and one of the first people to develop a monthly oral contraceptive pill. So a real landmark achieving endocrinologist. We have 6 presenters this morning from across the globe who'll be each introduced consecutively. And I'm going to hand over now to Tommaso Simoncini, who will now explain the process that we're going to go through this morning. Tommaso.
Thank you, Professor Davis. It's a real pleasure as the chair of the committee that has selected the 6 candidates for this prestigious award. It's a pleasure to be here and to see so many people connected tonight. So thank you so much for being with us, particularly to listen to the candidates. So tonight we will have 6 outstanding presentations, I'm sure. The rules are that we ask the candidates to stay within 10 minutes. So we want to assess not just the contents, but also the ability to present, the clarity, the synthesis, and the depth of thought and insight that they have in their research. And then we will have about 5 minutes of discussion. And for the audience, we have over 100 persons, actually it's nearly 150 persons connected. You are all welcome, like in any Congress symposium, to ask questions. And the questions will be just after each presentation. And anyone who wants to ask questions, you will have to write the question in the Q&A box. So we will be able to see the questions, and then we will select the questions for the candidates in case there are too many. So having said that, I think it's time to start and to give space to science. So it's my pleasure to introduce the first speaker. First speaker is Dr. Anouk de Wit. She comes from the Netherlands, from Groningen. But she's also affiliated with the Department of Psychiatry at the Brigham and Women's Hospital at the Harvard Medical School. I was there as well, not in the psychiatry, but in the cardiovascular disease department. So it's very near to my heart. So she's going to present an abstract presentation on the predictors of irritability symptoms in mildly depressed perimenopausal women. Anouk, the floor is yours. Good luck.
Well, hi everyone, good evening, good morning. Thank you so much for giving me the opportunity to present you our work here today. My name is Anouk de Wit. I'm a medical doctor, but I'm also an MPH and PhD candidate, both degrees I hope to finish in a couple of months. Today I will present work on which I did while I was a visiting PhD at the Brigham and Women's Hospital in Hedin Jafi's lab. Currently, I'm back in the Netherlands, working at the University of Groningen, and I hope that I can convince you to study irritability during the perimenopause. I have no financial relationships to disclose, so we can start. First of all, what is irritability? Irritability is a state of being abnormally responsive to slight stimuli. It's not a distinct disorder, so it's not like anxiety or depression, but still it's very prevalent. And the interesting thing for me is that you do see an increase in the prevalence of irritability during the perimenopause of 40%. And together with the fact that it's very burdensome on personal level as it reduces your quality of life, but also as it creates frustration among others, I think that highlights why we should gain insight in irritability during the perimenopause. Unfortunately, there's not much known. There are some risk factors, such as a younger age, being early perimenopausal, having more vasomotor symptoms, having a disturbed sleep, or more life events that all put you at risk for irritability. But those are not specific, because if you would check the risk factors for perimenopausal depression, you would find the exact same risk factors. History of premenstrual syndrome is a bit more specific, which kind of makes sense because premenstrual syndrome is characterized by irritability and more than it is, but then by depression. The risk factors I show here on the left are based on large epidemiological, great epidemiological studies, but unfortunately, those studies did not have access to validated irritability measures, and they also did not study measures of hormonal dynamics. And I think that's a pity, because the perimenopause is characterized by fluctuations in hormones, so at least it would, to my opinion, be very interesting to study the relationship between hormonal dynamics and irritability. So that brings me to the aim of the study, which was to determine the risk factors for irritability during the perimenopause. We conducted an observational study in perimenopausal women who were categorized based on the STROG criteria, and they had mild to moderate depressive symptoms or moderate irritability. We excluded those women who had menstrual irregularities attributable to other conditions than perimenopause, who had a history of severe psychiatric illness within the last 5 years, had a sleep disorder, or who were using medication that alter mood or vasomotor symptoms. We followed those women, those 15 women, over 8 weeks. And every week we measured their irritability, obviously, but also depression severity, the vasomotor symptom frequency, the insomnia severity with well-validated questionnaires. And we also measured hormone levels, such as estradiol and progesterone with LCMS and FSH with ELISA. And we repeated every measure every week, so we could really gain some insight in the dynamics of the perimenopause. Those hormonal predictors need a bit more explanation. There are multiple ways how you can analyze that data. The most basic approach would be to measure a single serum level and associate that with a single irritability score, but that would kind of be a cross-sectional analysis and would not capture the dynamics of the perimenopause. So we thought of 2 additional variability measures, of which one was a weekly change in estradiol or progesterone being related to a change in irritability of that same week. And we also included a more general measure of variation, which was the coefficient of variation. And we did that because we're not sure about what would be the right time span to measure those hormones. And this coefficient of variation is calculated based on the personal mean divided by the personal standard deviation. So it's really a like woman-specific variation variable. Those women were aged 48 years. They were slightly overweight, mildly depressed, of course. And they, I think, which already is interesting, is that at least during half of the visits, they showed moderate irritability. And as I promised you to give you some insights in the dynamics, here I just plot some women, so there are only 6, this is not all the data. And you can see that every line is a single participant. You can see that there is a huge variation. So some women have it from week to week, have a steep decrease, but an increase and then a decrease again in irritability. Whereas other women are quite stable, and the same is for estradiol. Then we move on to the main part of this study, and where we try to determine risk factors for irritability during the perimenopause. We use GEE modeling, a multi-level way of analyzing the data, because we had clustering within persons, and we lowered the cutoff for significance to 0.017 as we did multiple testing. In order to be a potential predictor, to be a risk factor, we said that it should be significant in a univariate analysis, meaning that a single predictor was associated with with irritability, but also that it had to be significant in the multivariate analysis, in which all the significant univariate analyses were combined. And here it's showing that less variability in estradiol, younger age, more frequent vasomotor symptoms, and more depression symptom severity are all associated with higher irritability levels. But that's not it, because we've shown that only these 4 factors only explain 30% of the variance in irritability. Still 70% was unknown. And of this 30%, which we could explain, depressive symptoms was the major predictor. Other factors, such as vasomotor symptoms and age, I think those are we expected that because we've seen that in previous research. You do see it in depression research. But one which is very interesting is the less variability being associated with more irritability. And I want to give you some more background, like how come estradiol can be associated with irritability. And imagine that we have sex steroid receptors throughout our brain. We have them in our limbic system, we have them in our reward system, and those systems are likely involved in irritability. By those sex steroid receptors, estradiol can alter gene transcription, but estradiol, for example, can also influence neurotransmitter release of serotonin or dopamine, which are probably also involved in irritability. So although this study doesn't give the mechanisms, it's kind of give you a background why estradiol could be related to irritability. It's still interesting that in depression research, we find the same association to be the opposite direction. So meaning that more irritability or more estradiol variability be related to more depressive symptom severity. And we still can't explain that. But if that's true, and if it can be replicated by others, and if we can replicate it in an experimental study, that would mean that suppression of estradiol variability might improve depressed mood, but not ameliorate irritability. We had some strengths and limitations. We had multiple time points within individuals, and we use well-validated measures for both estradiol, progesterone, and irritability. Also some limitations. It precludes causal inference. We have an observational study. We're also not sure about whether we had the right time spent to measure the hormones. It might be better to measure it day by day, for example. And it's questionable whether it applies to non-depressed women as well, because our sample was mildly depressed. So the take-home messages. Irritability is prevalent among mildly depressed perimenopausal women, which only partly can be explained by the severity of depression. Symptoms and hormones vary during the perimenopause, which highlight the need for multiple measurements within individuals. And decreased rather than increased variability in estradiol levels was associated with more irritability, which might suggest that irritability is linked with different estradiol dynamics than depression. Thank you so much for listening. Thank you also to my co-authors. I think Alida and Eric are here. I would be happy to answer any question.
Well, thank you so much. It was a very nice presentation. Thank you for staying perfectly on time, actually 20 seconds less. So I'll hand over to Professor Susan Davis, the discussion of the session. So we will alternate on the candidates. Susan, do you want to, I see we have a question in the audience. I think you're muted, Susan. So.
Sorry, you can see my mouth move. The first question we have is, did you capture prior menstrual history or menstrual history during the study? And was there any association with menstrual cyclicity and irritability?
Unfortunately, no, we didn't. No. I'm sorry. Oh, no.
So you didn't know what stage of the menstrual cycle you're sampling the estradiol. You didn't match it with bleeding?
No, we didn't. No.
And so carrying on from that question, if you were to redesign the study, you showed that a large proportion of the irritability was unexplained. What factors do you think would be important to capture in terms of assessing other factors? What other factors do you think could be important?
Yeah, I'm not sure if it would be like other factors. It might also be that we have to measure them at different time points. So for example, now we've shown that a weekly increase in estradiol wasn't associated with irritability. But it might be that we don't have, like, we shouldn't measure it weekly, but we should measure it daily or every hour. So it might be that it's not that we have to look at physical activity, for example, but it might be that we have to measure more often or maybe less often.
So what about factors then, like whether they were partnered or working or had children, or life factors? You don't think that they would be important to know about?
It would definitely be interesting to explore them. Yeah, definitely. I don't think we had factors like education, BMI, such factors. We didn't include marital status, but we definitely have the data, so we could do that.
Okay, and the question that's come through then is that should these women be given hormone therapy for their mood?
Well, I think there are the studies done. Like this is an observational study. So based on this study, we can't say anything about we should give women hormonal replacement therapy. We should do an experimental study for that. I know there are some studies in perimenopausal depression, but that has not been done for irritability. So it first needs an experimental design to show that. We definitely could organize such study. I would be very interested in doing such study, but not based on these findings that we should give women hormonal replacement therapy.
Look, I would also have a question if Susan allows. Thank you. Very interesting. Since these women were having probably very few ovulations in this advanced phase, was there any, since starting from the concept that women with PMS tend to have irritability symptoms associated with also physical symptoms of in the premenstrual phase, was there any suggestion that the overall levels of progesterone or the overall levels, absolute levels of estradiol, independently from the variations, were associated with irritability in these women?
No. We did a similar study in women. We showed that with depressive symptoms, in those women we saw an association with progesterone. We didn't see it in this study. And for example, I think again, it could be that because we measure weekly, we actually might miss an ovulation. So if a woman increases on Wednesday and decreases on Friday, and we measure on Sunday, and the next Sunday we just miss the peak. So I wouldn't say there is by no means an association, but we couldn't capture it in this study.
Thank you.
I think we probably need to move on. Tommaso, do you agree? Yes?
Okay.
Thank you very much for joining us. Our next presentation is from Juliana Kling. Juliana is associated with the Mayo Clinic in the US. And she is going to talk to us about associations of estrone and cognitive performance in recently menopausal women using hormone therapy. So I'll now open the floor to Juliana. Thank you.
Okay, just checking to make sure I'm unmuted there. Good day. It's such an honor and a privilege to be presenting our research in this virtual format at the Greenblatt Award through the International Menopause Society. Thank you so much. As you heard, my name is Dr. Jewel Kling. I'm an associate professor of medicine, as well as the interim chair of the Division of Women's Health Internal Medicine at Mayo Clinic, Arizona. And today I'm going to be presenting our study entitled Associations of Estrone and Cognitive Performance in Recently Menopausal Women Using Hormone Therapy, on behalf of myself and my co-authors, Dr. Dowling, Dr. Bamonte Nelson, Dr. Gleason, Dr. Contarsi, Dr. Stonington, and Dr. Miller. I have no financial relationships to disclose. Hormone therapy may impact production of androgens, including testosterone and androstenedione from the postmenopausal ovary. Additionally, the feedback regulation of hypothalamic pituitary hormones could be associated with physiological as well as neurobehavioral consequences. For example, in preclinical studies, higher endogenous plasma levels of androstenedione correlated with impaired cognition, regardless of administration of menopausal hormone therapy. Furthermore, conversion of androstenedione to estrone was in part responsible for memory impairment, but we don't know if these relationships exist in women. What we do know are that there are complex hypopituitary or ovarian feedback that has impact on various outcomes, as pictorially represented here in this graphic of the brain-body connection. We have previously shown in our group of recently menopausal women on hormone therapy that there were differences in hormone association based on hormone therapy treatment. In fact, you can see this here pictorially displayed, the associations for pituitary ovarian hormones by treatment arm over time. So from baseline to month 48, where the blue circles present or represent pituitary hormones and the orange circles represent ovarian hormones. The thickness of the lines indicates the strength of the association between the variables, the thicker the lines representing stronger association, and the line colors indicating the direction of the association, where green lines are positive association and red lines are negative associations. I demonstrate this to you or show it to you so that you can see that the associations of the hormones were different based on the different randomization group. However, how these hormone relationships or associations associate with cognition is not fully known. Therefore, the objective of our study was to examine associations among pituitary ovarian hormone levels and cognitive changes in women enrolled in the cognitive and affective study of the Chronos Early Estrogen Prevention Study. Women who underwent natural menopause, aged 42 to 56 years of age, were randomized to one of three arms. The first arm was a transdermal estradiol at 50 micrograms per day with oral micronized progesterone 200 milligrams per day for the first 12 days of the month. The second was an oral conjugated equine estrogen at 0.045 milligrams per day, as well with the oral micronized progesterone for the first 12 days of the month, or placebo. Hormone levels and neuropsychological testing were done prior to and 48 months after randomization. And 11 neuropsychological tests were summarized as 5 orthogonal cognitive domains that included verbal learning and memory, auditory attention and working memory, visual attention and executive function, speeded language and mental flexibility, as well as global cognition. 6 different hormone levels were evaluated by high sensitive liquid chromatography mass spectroscopy here at Mayo Clinic and included estrone, 17-beta estradiol, follicle stimulating hormone, luteinizing hormone, androstenedione, and testosterone. For our statistical analysis, we used a latent growth curve model that controlled for demographics as well as the randomization groups. And this allowed us to examine trajectories of each cognitive domain controlling for hormonal effects on cognition. Now, the hormone levels were modeled as time-dependent covariates. Here is a graphical representation of the model. And you can see that this model examines the effects of hormone levels at baseline and at month 48 and hormone therapy on the changes in cognitive function over 4 years of hormone therapy. Initial level and rate of change in cognition was adjusted for hormone therapy arm demographics and interactions at each time point. Women compliant to treatment, as well as compliant to cognitive testing at 48 months of the study, included 109 women that were in the oral conjugated equine estrogen group, 107 in the transdermal estrogen group, and 146 in our placebo group. This table demonstrates some of the participant demographics, including, importantly, the average age. You can see is 52 years of age, which fits with that recently menopausal stage or time period. This also is consistent with the years since menopause. That was anywhere from 1.35 for our placebo group to 1.49 for our transdermal estrogen group. The ethnicity of the participants are included here, and you can see that predominantly the women studied were white or Caucasian, but we did have representation from Asian Indian, Black African American, Chinese, Filipino, Hispanic, and Japanese. This table displays the hormone levels by treatment arm at baseline, which are displayed in the top 3 rows, and the hormone levels at month 48, which are displayed in the bottom 3 rows. Each of the columns represent the hormone levels. Now I'm going to direct your attention specifically to estrone, as that is the positive finding in our study. And you can see when we look at placebo from baseline to month 48, that level did not in fact change at all. Then when we look at the transdermal estrogen group, you can see the baseline was similar to the other groups and then about doubled over time. And then for the oral conjugated equine estrogen group, that significantly increased, which would be anticipated, seeing as oral conjugated equine estrogen is predominantly made of estrone sulfate. Our results showed that baseline higher levels of estrone associated with poorer cognitive performance at 48 months after controlling for hormone therapy or randomization group and demographics in the following cognitive domains: global cognition, visual attention and executive function, auditory attention, and working memory, all with statistically significant findings. So it appears that baseline hormone levels may have an impact on specific cognitive domains over time in recently menopausal women who have undergone natural menopause. This finding is consistent with the preclinical studies discussed earlier, which had showed that blocking conversion of androstenedione to estrone obviated the negative effects of androstenedione on cognition, indicating that it's the conversion of androstenedione to estrone that's in part responsible from its memory impairments. Now, estrone is a relatively weak estrogen aromatized from androstenedione, as well as a precursor and a metabolite to estradiol. Some of the metabolism also occurs at the tissue level. So much still remains to be learned about how metabolism of estrone, as well as the androgens and estradiol, affect neuronal and cognitive activity. So I'd like to thank my co-authors, as well as the Chronos Early Estrogen Prevention Study and Mayo Clinic, who helped provide the funding for this study. I will take questions. Thank you.
Well, thank you very much for that fascinating study. Maybe I will hand over now to Tommaso Simoncini regarding the questions.
Okay, thank you, Susan, and thank you, Jewel, for your very nice presentation as well, for staying on time. So we have a question from Professor Stephen Goldstein, the IMS president, and he's asking whether the randomization in the study was 1:1:1, and if so, how do you explain what seems to be a very large dropout rate in both hormone groups? So you would like to comment also on the relevance for the results that you showed?
Yeah, that's an excellent question. And it was a 1:1:1 randomization. Now, this particular study was a sub-study of the larger KEEPS trial, and we were only evaluating the women that were compliant to treatment as well as cognitive testing. And so there were likely lots of variables that may have impacted that difference in the numbers of participants with each of the groups. But we felt it important based on the outcomes we were looking at to only include those women that were compliant.
Great. And there's another question from Professor Nick Panay, and he's asking whether, he said that this was a healthy population, which is correct. So can you please speculate on the results if the population was cognitively impaired, which is, of course, very relevant in view of the WHI results?
And also an excellent question. Now, in the context of the WHI results, importantly, the KEEPS made sure to enroll women that were recently in menopause. And what our overall Keeps COGS study have demonstrated is that, in fact, menopausal hormone therapy, regardless of if it's the oral conjugated equine estrogen or the transdermal, did not negatively nor positively impact any of those cognitive outcomes. That's also been demonstrated in other studies, including one of the WHI sub-studies. How these results apply to cognitively impaired women are hard to know, since we are specifically studying early menopausal women, many of whom are, an excellent cognition. But it would be interesting to look at hormone associations. There is data looking at hormone manifestation or effects in the brain and how it relates to cognition in other sets of women. And so there's certainly something there that can be explored further.
Great. We have questions popping up, so I think you've done very well. So there's Professor Pinkerton who's asking if you think that the addition of testosterone to the estrogen would have an effect on cognition. And then there's a question from Dr. Pauline Maki coming up afterwards.
Excellent. Thank you, Dr. Pinkerton, for the question. Yeah, I guess we wouldn't be able to tell from these particular results because we were just looking at the potential impact of estrogen and progesterone on cognition. Although it would be interesting to look into that further. I know, in fact, Dr. Davis has done some of this research looking at the cognitive impact of testosterone and how that relates to the conversion of androstenedione. And perhaps it is the conversion of that to testosterone as opposed to estrone that may contribute to some of those findings.
Okay, we have two questions. One is from Pauline Maki, and then we have a question from Professor Davis. So Sue, I will hand you the podium afterwards, so you can move after Pauline's question. So Pauline is asking whether estrone levels in the study track with other estrogens seen conjugated equine estrogens. It may be that those estrogens, rather than estrone, relate to cognitive dysfunction. Were correlations similar in placebo and CE arms? So,
yeah, thank you very much, Dr. Mackey, for that question. While we did adjust or control for hormone therapy treatment and found, regardless, in all of the women that estrone associated with poor cognitive function at month 48. And in fact, estrone, or at least oral conjugated equine estrogen, does have many different estrogens, including a lot of estrone, and how that relates, including possibly at the receptor level, at the tissue level, may have some factor. But the fact that we saw the relationship regardless of the treatment arm points to possibly the endogenous estrone, or possibly even the metabolism of the hormones as a contributor.
Great. I think Susan had a question. So Susan.
So just a quick question. There have been many studies that have looked at peripheral blood levels of hormones and tried to relate those to clinical outcomes, but we know the metabolism is very complicated. Do you really think that measurement of serum hormone levels is telling us what's happening inside cells and will explain differences between women?
That is an excellent question. And I think it gives us at least some insight to next steps of where to look at, because clearly we found some relationships here. But to your point, there's a lot that goes into estrogen metabolism, as well as its impact in the brain and at the peripheral tissues. And likely we need to evaluate those relationships to really understand, what's impacting cognition in peri and postmenopausal women.
I think probably we move on to the next candidate. So thank you so much.
Thank you very much.
We enjoyed it.
So our next candidate is Dr. Thaís Raisa Silva. And Thaís is coming from, is actually working in Porto Alegre in Brazil. So we're moving from continent to continent, which is amazing in this virtual setting. So Thaís is going to present her work on the effects of high protein, low glycemic index diet on lean body mass, strength, and physical performance in late postmenopausal women, a randomized controlled trial. Thaís, please.
So thank you so much for having me here. I'd like to say that I'm honored to have been selected as an award finalist of the Greenblatt Award 2020, and more than happy to share my work with you. So today I'm going to present the results of our randomized clinical trial about effects of high protein, low glycemic index diet on lean body mass, strength, and physical performance in late postmenopausal women. First of all, I have no financial relationships to disclose. So, declines in endogenous estrogen production during the menopausal transition have been associated with loss of lean body mass. In recent findings from the study of women's health across the nation, as you can observe here, the total lean body mass loss during the menopausal transition averaged 0.5%. On the other hand, there was an increase in body fat mass. These changes in body composition have been associated with increased risk of coronary heart disease and disability. According to the National Health and Nutrition Examination Survey, a specific group of participants with high muscle and low fat mass had the lowest mortality risk in comparison to the other body composition subtypes. However, despite the importance of preventing muscle mass loss during senescence, it remains controversial whether protein intake greater than the recommended daily allowance by the Institute of Medicine is needed in order to maintain protein anabolism in older adults. So the current protein RDA is we call 0.8 grams per kilogram, and is the same for all age groups. And it's the half of the mean observed in our previous study, cross-sectional study from our group that was associated with higher skeletal muscle mass index in 105 postmenopausal women. So after that, this present randomized control trial was designed in order to investigate the impact of increasing protein consumption to twice the RDA on lean body mass, muscle strength, and physical performance. So this was a parallel group RCT with apparently healthy postmenopausal women. Our trial was registered at clinical trial, and all participants were evaluated at baseline and after 3 and 6 months of intervention. So women receiving routine gynecological care were recruited at a private outpatient clinic in the city of Porto Alegre, here in Brazil. Our inclusion criteria were women over 65 years and ability to perform activities of daily living independently. Use of systemic menopause hormone therapy in the past 3 months, insulin therapy, previous diagnosis of heart disease, untreated thyroid disease, and other conditions affecting neuromuscular function were defined as exclusion criteria. All participants were randomly assigned to low glycemic index diets with control protein consumption at current RDA or twice the current RDA. To calculate the daily energy requirement for each individual participant, the total resting metabolic rate was obtained by indirect calorimetry and then multiplied by habitual physical activity level. So our participants with lower levels of vitamin D receive vitamin D3 supplements during the trial. In order to assess dietary compliance, 24-hour urinary nitrogen excretion was measured as a crude marker of protein intake. and about information about dietary intake was assessed with validated food frequency questionnaire and also with 3-day diet food recalls. Physical activity was measured with a digital pedometer, and we applied the International Physical Activity Questionnaire in addition. So all participants were asked to maintain their usual physical activity during the trial. So the outcomes. Body composition was assessed by DEXA. The primary outcome was change in the total lean body mass. Secondary outcomes included appendicular lean mass, whole body and trunk fat mass, and visceral adipose tissue. Other secondary outcomes included muscle strength assessed by grip strength and physical function assessed with the 4-meter usual walking gait speed test. Our sample size was based on the assumption that 26 participants across 2 groups would provide 80% power to detect a difference of 1.4 kilograms in LBM between interventions. So the results. Well, in total, 27 postmenopausal women met the eligibility criteria and only 1 participant withdrew before randomization. Here in table 1, we can observe the baseline characteristics of our sample according to the dietary intervention. So the mean age of our sample was 20.8 years, and years since menopause was 21.3. The 2 RDA group had lower BMI and waist circumference in comparison to the RDA group at baseline. However, body composition, muscle strength, and physical performance were similar between the groups. Also, at baseline, dietary intake did not differ between the groups. And during the intervention period, energy intake remained similar. However, protein intake was different. The 2 RDA group had a higher amount of protein intake during the study. The mean during the study was 1.4 grams per kilogram versus 1.1 grams per kilogram in the RDA group. Dietary glycemic index decreased in both groups during the intervention. And finally, the outcomes of our sample according to the dietary intervention. And as we can observe here, lean body mass increased significantly after 3 months of intervention in both groups. However, protein intake did not have a significant effect on LBM during the entire intervention, and controlling for BMI at baseline did not alter these findings. Regarding muscle strength, we observed that there was an increase in muscle strength at the end of intervention in both groups, and the same was found for physical performance, an increase during the study. And here in figure 2, we can observe that there was a similar decrease here in a total body fat mass and in trunk fat mass at the end of the study, and it was similar between groups. However, there was no significant effect of protein on visceral adipose tissue over six months. In conclusion, protein intake exceeding the RDA did not promote higher LBM or muscle strength and did not contribute to physical function gain when compared to the current RDA in apparently healthy late postmenopausal women consuming a low glycemic index diet for 6 months. Our findings suggest that the RDA may be sufficient to maintain LBM in older women. However, our findings need to be replicated in trials with large sample sizes and may not be applicable to men or frail elderly persons. So it was a great pleasure to share our results with you. Thank you so much for your attention.
Well, thank you so much, Thaís. And well, we'll wait for you to take the screen out. So I'll hand to Professor Davis for the discussion. I see we already have a couple of questions popping out.
Thank you very much for the presentation. So we do have questions popping up. Given the association between adipokines and hot flushes, I wonder if you have any data on how many women were still suffering from hot flushes at a later age, and was there any evidence of a high protein intake influencing vasomotor symptoms?
It's a great question, thank you. No, we didn't have access. We didn't access the vasomotor symptoms, and but it's a question that probably needs to further evaluation in other possible clinical trial. But until now, in our clinical trial, we didn't measure this. Only quality of life, and quality of life remained similar during the study. There was no significant effect of protein in quality of life.
So the next question is actually two questions. The first is, you obviously had a relatively healthy study sample. Did you consider having a third group of lower protein intake than recommended?
Yes, I think it's be important to evaluate this in other samples. Our postmenopausal women were relatively healthy, so it's completely different. But with our study, I only can say that in this population, maybe there is no significant effect of high protein in muscle mass and strength. I don't know if I answer your question.
I'll rephrase part of the question. So a high protein intake in older people can have good effects and bad effects. Is there a concern about adding extra protein? And therefore, did you consider having a third study arm where you gave women less protein than is usually recommended?
Okay, thank you. So it's our concern. We measured other aspects of biochemical variables and renal function and other aspects of health, and there was no side effects of high protein, no deleterious effect of high protein in our sample. So maybe in our sample, high protein, it's completely completely safe. Sorry. And yes, maybe a third group with less than RDA protein maybe suffer, because I think protein it's important, but moderate amounts, not too much protein, as we can imagine before or supposed before our trial and other clinical trials that have shown similar results with ours.
So we also have a question, can the lack of difference between the groups possibly be explained by inability to metabolize the extra protein, particularly if exercise is not increased?
Yes, it's a good question. Maybe, because probably when we increased our physical activity level, we need more protein, since since previous clinical trials have demonstrated that. But it's probably one explanation that we could have find any difference in our interventions group.
And following on from that, there was a question, if you had older women who had high levels of physical activity, someone suggested older runners, but high levels of physical activity, do you think there might be a difference?
With heart levels?
higher levels of physical activity, more active women, like if they were jogging or working in the fields, doing anything?
Our sample had a moderate level of physical activity. So I don't know, maybe, but we need further clinical trials to evaluate this possibility. But I think other aspects of diet are much more important than only protein. I think we can look with other aspects of diet, include dietary glycemic index, that we observed that with the decrease of dietary glycemic index, which was associated with increase in muscle strength and physical performance. So maybe it is an aspect of the diet that needs further evaluation, and it's associated probably with muscle strength.
Thank you. Tommaso, do you have any further questions?
No, I'm actually okay. So do you want to move on with the next presentation?
Thank you very much, Thaís.
Thank you. Thank you.
So our next presenter is from Melbourne, Australia, from Monash University. And we have Stephanie Tan, who's going to present to us. And Stephanie is going to speak about the associations between age, sex, and menopause and brain structures. So I'll pass on to Stephanie.
Hi, everyone. Can you hear me okay, Susan?
Thank you.
Fantastic. Hi, I'm Stephanie Tan. I'm a geriatrician or a specialist for older people, as well as a PhD candidate from Melbourne, Australia. My talk is on the associations of age, sex, and menopause with brain structure. And again, I'd like to thank the organisers for inviting me to speak today. I firstly have no financial relationships to disclose. So there are multiple risk factors associated with an increased risk of dementia. Advancing age is the most important one, as well as genetic factors such as being a carrier for the apolipoprotein E4 allele. Studies also indicate that female sex is a major risk factor for developing dementia, with women comprising 2/3 of people living with the condition. And it appears that longevity does not wholly explain the higher frequency, nor the higher lifetime risk. It's likely that changes in the brain develop decades prior to cognitive symptoms, and therefore midlife may be a critical period in the natural course of dementia. For women, this time coincides with menopause, a transition marked by decline in ovarian hormone production, and it's also a time when many women experience neurological symptoms and cognitive complaints. A few studies have assessed the association between sex, menopause, and brain structures, but all have adjusted or fixed the effect of age as a covariate, assuming an independent effect to sex and menopause. However, an interaction between age, sex, and menopause has not previously been studied. And this is important because the time of life that menopause emerges is a significant factor in dementia risk, and we can't therefore assume that the effect of menopause is constant at all time points. For example, both surgical and premature menopause are associated with an increased risk of cognitive dysfunction. My aims were to therefore assess the associations between sex and brain structure in midlife and how this association may be modified by age, and to also explore the role of menopause in explaining any such sex differences, and instead of fixing the effect of age, to explore for an interaction with age. My hypotheses are that the associations between age and brain structure are greater in women than men in a middle-aged sample, and that the associations between age and brain structure are greater in postmenopausal women compared with premenopausal women. Data were obtained from the UK Biobank, a population cohort from the United Kingdom of about 500,000 participants aged 40 to 69 years at time of recruitment. Participants visited an assessment centre for the collection of extensive health and lifestyle information, physical and cognitive measures, biological samples, and genotyping data. From 2014, approximately 15,000 participants attended for MRI scanning, and measurements included total brain, grey matter, white matter, and white matter hyperintensity volumes. On the right are MRI images defining grey matter, white matter, and white matter hyperintensities. And please note that the atrophy of grey white matter and an increase in white matter hyperintensity volumes are both associated with more cognitive decline and a higher dementia risk. For this study, I only included participants with brain MRIs who also had complete cardiometabolic data. For my analysis, I used simple summary statistics to describe the sample, and brain volume measures were normalized by head size. I used linear regression to examine the association between age, sex, menopause, and brain volume measures. I then examined for statistical interactions between age and sex on brain volume measures and interactions between age and menopause on brain volume measures. This table shows results describing the sample. Complete data were available for 4,222 people. A total of 2,165 participants were men and 2,057 were women. Of the women, approximately 11% were premenopausal and the remaining were postmenopausal. The median age of men and postmenopausal women was 64 years, and for premenopausal women, it was 50 years. The majority of the participants were white, and men were more likely to have cardiometabolic conditions such as diabetes and hypertension. The proportions of participants carrying at least one ApoE4 allele was similar between the three groups, approximately a quarter. 7% of postmenopausal women had had a history of a bilateral oophorectomy, and 40% were currently on or previously on menopause hormonal therapy. These box plots compare the differences in brain volumes between men and women, scaled by head size in total brain, grey matter, white matter, and white matter hyperintensity volumes. The red refers to men and the blue to women. On the far left, you can see that when normalized by head size, men have overall smaller total brain volumes compared with women. This sex difference is again notable in grey matter, with men having smaller grey matter volumes compared with women. However, for white matter volumes, men have just slightly larger volumes than women. I then looked at the volume of white matter hyperintensities between sexes. On the far right are box plots showing that on average, men have accumulated a greater volume of white matter hyperintensities than women. These graphs plot the association between age on the x-axis and brain volumes on the y-axis and its interaction with sex. All results are adjusted for by ApoE4 status. At the bottom are beta coefficients and their 95% confidence intervals. The p-values refer to the statistical interaction between age and sex on brain outcomes. The figure on the left shows the association between age and total brain volume and the effect of sex. You can see that the steeper slope of the blue line indicates that the effect of age on total brain volume is greater or more negative in women when compared with men. When I explored for interactions between age and sex in grey matter volumes, I found that again, there was an age-sex interaction with a greater negative effect of age on grey matter volume in women compared with men. I found no statistically significant age-sex interactions in white matter volumes or white matter hyperintensity volumes. These box plots present the differences in brain volumes between pre- and postmenopausal women, scaled by head size in the same four brain regions: total brain, grey matter, and white matter hyperintensity volumes. The yellow mustard colour refers to premenopause and the blue to postmenopause. On the far left are box plots comparing the mean total brain volumes between the two groups, and you can see that on average, total brain volumes for postmenopausal women are smaller than those in premenopause. Again, the same difference is noted in mean grey matter and white matter volumes. I then looked at the volume of white matter hyperintensities between the groups, and you can see that on average, postmenopausal women have accumulated a greater burden of white matter hyperintensities than women in premenopause. I then incorporated age into the mix, and these graphs plot the associations between age on the x-axis and brain volumes on the y-axis, and its interaction with menopause status adjusted for by ApoE4 status. For total brain volume, on the far left, the steeper blue line suggests a significant interaction between age and menopause, such that the negative effect of age on total brain volume is significantly greater in postmenopausal women. I also found a significant interaction between menopause and age with both grey and white matter volumes, with the steeper blue lines in both graphs indicating an age-menopause interaction. This indicates that the effect of age on total grey and white matter volumes is significantly greater in postmenopausal women. For white matter hyperintensity volumes, you can see that although there was a visual difference in the slopes, it was not statistically significant. MHT use in this study did not modify the association of age with brain structure, and nor did time since menopause in years, or the reproductive period, which is the number of years between menarche and menopause. This was a large data set using good quality brain MRI data. However, there is an increased risk of misclassification with menopause status being self-reported, and I did use secondary data. So in conclusion, women have greater total brain and grey matter volumes than men at midlife. Sex modifies the associations of age with total brain and grey matter volumes, with a more negative effect of age observed in women than in men. Menopausal status appears to modify the associations of age with total brain, grey matter and white matter white matter volumes, with a more negative effect observed in postmenopausal women compared with premenopausal women. And in summary, age, female sex, and menopause appear to have synergistic effects on brain structure. I'd like to acknowledge my supervisors for their contributions to this project, and I would be happy to take questions.
Thank you very much for that, Stephanie. Before I pass over for my co-chair, we don't have questions coming up, so I'll take the chair's prerogative and ask you a couple of questions. You say that your conclusion about sex modifying the associations between these variables and brains, brain structures, but the men had more comorbidity. So what happens when you take into account the whole, particularly in the UK sample, which we know there's a high rate of cardiovascular disease in the UK. If you took into account all these comorbidities, is there really an effect of gender, or is it an effect of greater vulnerability of men to be unwell at that age?
Well, you'd expect that, you'd expect if, given there are more comorbidities in men, particularly cardiometabolic risk factors, that they would have a more rapid decline in the slope. So I was a little bit surprised when I saw the data. We did incorporate a simple cumulative cardiometabolic risk score into the regression model, and that didn't really alter the interactions at all. It didn't really have a big signal. So I think in future studies, I would like to use more sophisticated methods or analytic techniques to see whether or not, healthier, maybe there are different phenotypes of postmenopausal women or different phenotypes of men that may have varying associations with brain structure. So I do agree with your point. It was an interesting finding that men tended to have more cardiovascular risk factors, and that may also explain why women begin at a higher baseline. Women, as we know, don't tend to develop metabolic syndrome until around the time of menopause. They're relatively healthy compared to their male counterparts, and then there's this leveling out in terms of body adiposity, fat distribution, lipid levels, etc. So I think further studies using more sophisticated risk scores might be useful.
And I'll pass over to Marcia because I see a number of questions coming through.
I think you gave it a starter, and there's a lot of questions for Stephanie. So I'll start with a question on from Joanne Pinkerton, and Joanne is asking whether the findings on that menopause and age affect white matter hyperintensity as well as total gray and white matter. So she's asking whether ApoE affect these changes with age as well. So is there any association between ApoE status and age on these parameters?
So I did adjust for ApoE4 in all my analyses, and I didn't unfortunately find a signal. Whether or not I didn't examine for an interaction between ApoE and age, because that wasn't the main aim of my study, to look at ApoE versus age, but certainly previous studies have shown that ApoE is more detrimental for female carriers than male carriers. But in my study, they were fairly proportionate in terms of the number of people with ApoE4 across the groups. But unfortunately, that wasn't the main aim of my study. Yeah, I didn't find a signal when I incorporated it as a covariable.
Great. And still Joanne, she's asking a question that is actually shared by Delphine Tan from the Philippines. And they both ask information on timing when MHT, menopausal hormone therapy, was started, duration, type. So is there any relationship between timing and doses or types of routes with these results on whether, you know? Yeah.
I wish I could answer that question. It's such a topical topic at the moment, if I can say topical topic. I didn't unfortunately have information or detailed information about MHT use or even the menopause itself. It was all self-reported, whether or not they'd had menopause, if they'd ever used MHT or currently were on. It was a single yes, no answer. I didn't unfortunately have information about the indication, type, duration, or even onset. And we know that onset of MHT use is particularly important in our perimenopausal and postmenopausal women. Despite that, I think there are some parallels with the timing hypothesis. So MHT is apparently beneficial early in perimenopause and may have detrimental effects in late menopause. And my study indicates that the effect of sex and menopause in women is more impactful as a woman ages. And I guess that's what I'd like my audience to take away from my talk today. And given that age interacts with sex and menopause, it could mean that there are other risk factors such as MHT that also interact with sex and menopause. But age is not modifiable. Maybe there are more modifiable risk factors, as Susan mentioned, cardiometabolic risk factors.
Right. Well, thank you, Stephanie. And I think you've answered also indirectly to Nick Panay's question. He's asking whether there's such solid data to draw any firm conclusion about the role of menopausal hormone therapy, which I think you already answered. So Joanne is also asking whether there is any effect of surgical menopause at an early age on brain volume or on the hyperintensities as compared to natural menopause. So when you compare surgical and natural menopause at an early age, are they different in terms of relationship with these morphological features?
I didn't look at that, but I will go back and go into my computer and do that soon. Unfortunately, I can't answer that question. I assume that this relatively young sample from the UK would have had MHT replacement from the time of surgical menopause if they were treated appropriately. And previous studies haven't suggested that they are at a disadvantage when it comes to if they've had the proper treatment, but it'd be interesting to look at this sample. I'm happy to discuss further with Professor at a later stage.
I have one last question to myself, if I may.
Yeah, sure.
So you say there is an effect of menopause, but if I understand that the women were not age matched for pre and postmenopausal, so how are you sure it's just not an accelerated change with aging and menopause has nothing to do with the whole situation?
Yeah, that's a really valid point, Professor Davis. And I think you noticed on my graphs that the yellow, or I think it was the mustard, the yellow dots stopped at a certain point because then they transitioned into postmenopause, whereas we had a whole heap of older postmenopausal women. And I was afraid that they were biasing the results as well by pulling the slopes downwards. I did look at a subgroup of women under the age of the oldest premenopausal woman, which was 58 years. So they were, I wouldn't say they were age matched, but they were, under the age of a certain time point. And I still found that an interaction persisted in total brain and grey matter, not white matter volumes though. So that's an interesting finding, which I wouldn't be able to explain away right now. But yeah, so there was a persistent interaction if you cut the age limit.
Thank you.
Thank you.
Stephanie, one last question on my side. I assume there's no such information in the biobank to answer, but is there any indication that you can draw that the environment when a person is where a person is living in? I mean, are these persons living in a family, or are they socially active? Are they culturally different in groups? Whether these influence also their morphological feature, or is there any relationship with the brain morphology throughout age?
Yeah, there are so many risk factors that could be involved in explaining these interactions. We did have some data on, whether or not they received a tertiary degree, for example, and certainly postmenopausal women, as you would imagine, had less opportunity to achieve a higher education. We did also have some proxy measures for physical activity, such as accelerometer data and MET scores. Ethnicity we also had, but a lot of it was also self-reported. I didn't incorporate all of those factors because that would be too busy, that sort of regression model. But the most important ones that we know are associated with dementia and cognitive decline didn't seem to impact that interaction.
Well, thank you so much. So if Susan agrees, I would move on to the next candidate. And so thank you so much, Stephanie, for your wonderful presentation. So the next speaker is Dr. Jia Zheng. I hope I pronounced it right. And she's actually from Monash University as well. And she's going to speak about the female sexual well-being across the Australian adult lifespan. Jia, the floor is yours.
Thank you. I'm Jia. I'm actually a final year medical student, and I'm absolutely delighted to be here presenting at this online award symposium from Melbourne today. I have no financial relationships to disclose, and I'd also like to begin by acknowledging the grants that have made this research possible. In today's presentation, I'll be focusing on one of the many aspects of sexual function, sexual desire. Women can experience low sexual desire, which is the lack or loss of interest in sexual activity, and they can also experience sexually related personal distress. When women have low sexual desire in association with distress, they can be considered to have hypoactive sexual desire dysfunction, HSDD. A diagnosis of HSDD requires the exclusion of other factors, and a clinical diagnosis requires a face-to-face assessment. However, in large samples, a face-to-face assessment is not always feasible, and instead validated questionnaires are used to estimate the prevalence of HSDD. These questionnaires, however, are unable to exclude those other factors. To distinguish this from clinically diagnosed HSDD, I've used the term epidemiological HSDD or EHSDD to refer to HSDD that is identified using these questionnaires. In the past, there's been few studies looking at sexual desire, distress, and EHSDD across the female lifespan. They've often focused on a particular age group. And past studies have also had limitations, including the lack of an assessment of sexual distress, recruiting only sexually active or partnered women, and using convenient sampling. Therefore, my aim was to report the prevalence of low sexual desire associated distress and EHSDD, as well as looking at the psychosocial factors associated with each of these outcomes across the Australian adult female lifespan. I had the unique opportunity to include data from 3 existing representative cross-sectional studies. The first was the Groller-Rosine Young Women study, which had almost 7,000 women complete online questionnaires, and they were from the eastern states of Australia. There was approximately 2,000 Australian women at midlife and approximately 1,500 older Australian women who completed written questionnaires, and they were from all across Australia. The greatest strength of these 3 studies were that they were representative on a number of different socio-demographic factors, including location of residence, their BMI, and their partnership status when compared to the Australian Bureau of Statistics census data. And all of these women were recruited from the community between 2013 and 2017. The younger women completed the Profile Female Sexual Function, PFSF questionnaire, whereas the older women completed the Female Sexual Function Index, FSFI questionnaire. And the FSFI desire domain comprises of 2 items, one about frequency and one about degree of sexual desire. In order to merge the desire data, I selected the question about frequency as there was very similarly worded items in the PFSF. So in the PFSF, the question was, how often in the past 30 days did the following statement apply to you? I felt sexual desire. And for the FSFI, it was over the past 4 weeks, how often did you feel sexual desire or interest? And women had to choose the responses corresponding with the 2 lowest frequencies to be considered to have low sexual desire. All women completed the same validated sexual function distress scale, and a validated cutoff was used to define sexual distress. Again, for women to be considered to have EHSDD, they needed both the low sexual desire as well as the distress. Overall, we had over 10,500 Australian women, 2/3 who were sexually active and 2/3 who were partnered. 10,514 completed the required desire item, and slightly fewer completed the full 13-item sexual distress questionnaire. I was able to classify 10,259 women as either having or not having EHSDD. The results were that the prevalence of low sexual desire was lowest in the youngest age groups, where about 30% of those between 18 to 34 were considered to have low sexual desire. Was intermediate among midlife, where about 60% of those between 40 and 54 were considered to have low sexual desire, and was highest in the oldest age groups, where approximately 90% of those 65 and above met the same criteria. In contrast, the prevalence of sex-related personal distress was highest in the youngest age groups, where approximately 50% of those between 25 and 39 were considered to have sex-related personal distress, and was much lower in the older age groups, where less than 25% of those 65 and above met that same validated cutoff. The prevalence of EHSDD was highest among midlife, where about 1/3 of women between 40 and 64 were considered to have EHSDD, and the prevalence was lowest at the 2 age extremes. This slide reiterates what we saw in the previous 3 slides, but from a slightly different perspective. These numbers here are the odds ratios adjusted for several different socio-demographic factors, as well as the 95% confidence intervals. And they represent the likelihood of low desire in midlife in older women compared to that youngest 18 to 39 year age group. And as you can see, the likelihood of low desire was high in both midlife and older women compared to that youngest group. In contrast, the likelihood of sex-related personal distress was both lower in midlife and older women compared to that youngest group. And the likelihood of EHSDD was high in midlife compared to that younger group, and lower in older women compared to that younger group. I looked at the socio-demographic factors associated with low desire in the purple columns here, sex-related personal distress in the red, and EHSDD in the green. Again, these are the adjusted odds ratios for all the associations that were statistically significant in the final multivariable logistic regression models, and the 95% confidence intervals. So these odds ratios are relative to the value of 1. So a value higher than 1 indicates a positive association or a risk factor, and a value below 1 indicates a protective factor. The key findings here were that being married or in a de facto relationship being sexually inactive, or using psychotropic medications in the last 4 weeks was positively associated with all 3 outcomes. Being educated beyond secondary school was positively associated with sexual distress and EHSDD. And being a current smoker or a current alcohol drinker was positively associated with sexual distress. Being of Asian ethnicity compared to Caucasian ethnicity was the only socio-demographic factor that was found to be protective against all 3 outcomes. The strengths of this study included the use of large representative samples, psychometrically validated sexual function and sexual distress questionnaires, and the fact that the study sample was not limited by sexual preference, activity, or partnership status. The limitations included that desire was assessed with a single item from the FSFI or the PFSF, and that with the use of these questionnaires, primary causes for HSDD could not have been excluded. In conclusion, young Australian women were most likely to experience sex-related personal distress. Australian women at midlife had the highest prevalences of EHSDD, and the likelihood of EHSDD was higher in women who were partnered, sexually inactive, more educated, and taking psychotropic medications. Overall, this picture of sexual well-being across the lifespan should help health professionals to identify the women who are at the greatest risk of experiencing HSDD so that the appropriate support can be provided to them. This study was published earlier this year in the Journal of Sexual Medicine if you'd like to have a further read, and thank you for listening to my presentation, and I'm happy to answer questions.
Thank you so much, Jia, for sharing your data with us. Very interesting presentation indeed. So I'll carry on managing questions. So we already have questions popping up. So I'll start right away with the first one coming from Rosella Nappi. So she congratulates with you for the presentation. And she's asking whether you have any additional information on the use of hormonal contraception in younger women or recent pregnancy related to the onset or maintenance of HSDD in this population.
Yes, so in this study, unfortunately, we couldn't include age-specific factors as it was a study across the lifespan. However, I also did the study looking at the youngest woman, the Groller-Rosine study. And in that study, we did look at factors such as oral contraceptive use and whether they were currently pregnant. And oral contraceptive use was not associated with HSDD or low desire in that study. And we also looked at several other sexual function domains, and it wasn't significantly associated with any of those sexual dysfunctions.
Great. And there's a question from Nick Panay. He's asking whether you were able to look at the incidence of HSDD in women with premature ovarian insufficiency or early menopause as well.
So we did have data about the menopausal status of women, whether they were pre, peri, or postmenopausal, but we didn't include it in the multivariable logistic regression models because it had such a strong correlation with age. So that's not something we included in our final model.
Great. Thank you, Jia. And Joanne Pickerton is asking a couple of questions now. She's starting with a question on the use or is there any data on the use of antidepressants across the lifespan in each of the groups?
Yes, so it was approximately, I think, definitely in younger women, about 20% of the population used antidepressants, and I think it was similar in the 2 older groups as well. Or was using, sorry, not just antidepressants, but all the psychotropics that were listed on the questionnaire.
Okay. And she's also asking whether the data included the presence of dyspareunia in aging women while the women age, actually, so throughout the aging process.
So the FSFI does have questions about dyspareunia. but they, in the FSFI, you cannot answer the questions if you are not sexually active, so you automatically get a score of 0. So we didn't look at those other domains because it would have excluded large groups of our population.
Great. Any other question popping out from the no, not so far? Susan, do you want to add something? I know you're...
I'm on mute. No, I'm not on mute. So Jia, can you just explain whether there was, I think the question about the dyspareunia was, is that something that should be important in the analysis or included in the analysis? And was there any, effect of dyspareunia that you could look at in this study?
Yeah, so definitely I think dyspareunia would be important in including in a study about sexual distress. However, it would have to be perhaps only included in those women who are currently sexually active or able to say if they currently have dyspareunia or if they've previously experienced it, if we were looking at a wider group.
Great. So if there's no further question, I think we should congratulate Jia and we should move on with I think the last presenter today. Susan, do you want to introduce her? Thank you so much, Jia. Congratulations.
Our final presenter today is Alejandra Martínez García, who is from Santiago in Chile, who is presently working in Melbourne, Australia, and soon to return to Chile. And Alejandra is going to talk about normal ranges and determinants of circulating estrogens in older postmenopausal women. Thank you, Alejandra.
Thank you for the opportunity to present my work. I have no conflict of interest to report. And starting with the background of my study, in postmenopausal women, estrogen production is mostly within cells from hormones made by the adrenals, such as the IgA and androstenedione. And therefore, the low circulating estradiol levels in postmenopausal women probably is not reflecting what is happening inside the cells. This shows findings in estrone and estradiol concentrations in women aged 70 years and older from a study that we published recently. And you can see that over 99% of older women had estrone detectable levels. And however, 2/3 of older women had estradiol levels below the limit of detection or considered undetectable. So keeping that point in mind, most of the studies that already focus on the role, on the associations of estradiol with risk fractures and with other different types of cancers in postmenopausal women and in older women specifically. However, estrone has 1/10 of the potency of estradiol, but in postmenopausal women is circulating in about 100 times greater than estradiol. So its biological potency probably matters. The objective of my study is to evaluate what best predicts serum estradiol concentrations in older women and to determine the contribution of these several factors listed here to serum estradiol. My study included 5,325 older Australian women, not using any sex steroids, glucocorticoids, anti-glycemic agents, anti-estrogens, or anti-androgens. And all sex steroids were measured by liquid chromatography and tandem mass spectrometry at ANZAC Research Institute in Sydney. So how to deal with estradiol levels below the limit of detection, knowing that 2/3 of older women had undetectable estradiol levels. So for any sample with a low, an estradiol level below the limit of detection, we use the limit of detection divided by the root square root of 2. This has been shown to be the minimally biased method to overcome left censoring, and the imputed value for any sample with undetectable estradiol level was 7.7 picomole per liter. As part of my results, you can see here 2 box plots, one for estrone and one for estradiol, looking at only detectable levels. And estrone increases with age, which is significant, but detectable estradiol do not. So apart from age, what other factors influence estradiol levels? Knowing that estradiol is the most important biologically active estrogen, what it predicts it? Age, BMI, DHEA, testosterone, or estrone. So for that, I'm going to show you a series of graphs looking at correlations between estradiol and all the different variables that I already mentioned. And in these graphs on the left, you will see the detectable estradiol levels only, sorry. And on the right, you will see the total estradiol levels, detectable plus the imputed values. Rho tells about the strength of the association, and p-value about the significance of that association. I like to point out that the y-axis is in a logarithmic scale. And here you can see a weak but positive correlation between the total estradiol levels and age, but not between detectable estradiol levels and age. BMI is also a weak positive, but increasing positive correlation with estradiol. DHEA is stronger and has a moderate positive correlation, significant for both estradiol, detectable and total. Testosterone is even greater and has a moderate positive correlation with estradiol. But the strongest positive correlation was observed between estrone and estradiol and was significant in both. So I next evaluate if women with detectable versus undetectable estradiol levels were different in other sex steroids, in age, in BMI. And my study shows that all other sex steroids, including estrone, DHEA, and testosterone, women with detectable estradiol levels had higher other sex steroids compared with women with undetectable levels. In relation to age and BMI, women with detectable estradiol levels were younger and had a higher BMI. And in the univariate analysis for associations between estradiol, giving us detectable and total estradiol, remember, including detectable plus imputed data. And this is done twice for every variable performed. R square is showing that 14.2% of the variation in detectable estradiol is explained by estrone, and that 19.7% of the variation in total estradiol is explained by estrone. Testosterone explains about 9% of the variation, DHEA about 4% of the variation, and age and BMI even less. And consequently, most of the variation in estradiol is explained by estrone alone. For the final multivariable model, including estrone, testosterone, age, and BMI, all the variables that were significant in that model all together explain an additional 1.2% of the variation in total estradiol over estrone alone. Remember, 19.7% of the variation was for estrone alone. And the final model for detectable estradiol, including estrone and testosterone, explained together an additional 2% of the variation in detectable estradiol over estrone alone. So again, all the variables together only had a limited impact, and estrone is the most, or explains the principal variation in estradiol levels. I'd like to come back to this slide just to remind you that my study shows that maybe estrone is the best predictor of what is happening inside the cells. So in conclusions, for postmenopausal women aged 70 years and older, my study supports estrone as an important circulating estrogen, demonstrates that is the strongest predictor of circulating estrogen, also a surrogate marker for estradiol action, and maybe more meaningful than circulating estradiol. And altogether, measurements of estrone should be included in studies evaluating an association between estrogen concentrations and health outcomes in postmenopausal women. Thanks for your attention.
Thank you so much, Alejandra. Wonderful presentation. So I'll take also the discussion, and we already have a couple of questions coming. So congratulations again. First question is why did you choose women from 70 years and above? So what is age range particularly? Is that correct? Is that
Yes, because we didn't have like the value, or we didn't have hormone range levels in this group of women. So it's really important to know what is happening in older women. And thanks to my study, my study is showing that not only estradiol or low levels of estradiol is important, we're not seeing all the picture. We need to have all the picture to make an idea what is happening in these women. And estrone, you must include it to know what is really, really happening. And here, estrone, the important thing that in 90% of women, older women, is detectable. So it's an important hormone, but this has been dismissed. Every decade has been dismissed like an important hormone. And in these older women, it's circulating in about 100 times greater than estradiol. So even if it has 10% of the potency of estradiol, it is doing something. So to see the whole picture, we need to know about the estrone levels.
Great, and there's another couple of questions that look into the same direction. So Delphine Tan is asking whether the detectable estradiol in postmenopausal women will have a protective effect as compared to the group of women where there's no detectable estradiol. So this is on estradiol rather than on estrone.
Will the detectable estradiol have a protective effect?
Right.
And protective effect, maybe it's not especially the estradiol levels. Maybe we have we saw that women, older women, it's not just estradiol, it's for example, SHBG. You know that SHBG has a metabolic activity, and probably that is associated also with protective outcomes in these women, not just only the fact of having a low circulating estradiol level. Maybe it's all other aspects of hormones and binding globulins that are explaining this. probably.
Great. And there's a question from Dr. Pinkerton on the potential of measuring estrone to predict breast or endometrial cancer. So is there any reason to suppose that the levels of estrone that are much more reliable, as you said, in these elder women to correlate with the risk of these diseases?
I can say that almost most of the studies until today is being focused on associations of estradiol and the risk in different type of cancer risks in older women, as well as fracture risk. But as I said, estrone is circulating in 100 times greater than estradiol. So probably it matters. And that it's why my study is showing that is something that needs to be measured when you are seeking or evaluating health outcomes and this risk in older women.
Great. And another question from Dr. Ismail. He's asking whether it is important to know exactly the timing of the collection of the samples, because he says that there's a known variability in the concentration of circulating estrogens. Is this correct? Is this true? So is this important?
One of the strengths of my study is that all the success stories were measured by liquid chromatography and tandem mass spectrometry. So that it's like has high specificity and high sensitivity. So when you measure success stories by this method, probably all the fluctuations that you used to see with the other assays, this is not happening with the liquid chromatography. So that is a strength in my study.
Great. And is there any other question? I don't see any more. Turning the word to my co-chair, Professor Davis. Susan, do you have questions, or do you want to
I have no further questions. I think that we have had 6 wonderful presentations this morning. And I think I congratulate everybody on behalf of Professor Tommaso Simoncini and myself and the Society on all of your presentations. And it's been wonderful to see that we've had up to 200 people viewing today. So I think that's really shows the importance of this symposium. And now what we're going to do is that the judges are going to disappear. I'm going to give a brief summary of the issue that we have talked about in World Menopause Day and talk to you briefly about premature ovarian insufficiency. And while I'm giving this brief presentation, the judges are going to be discussing behind the scenes their evaluations of our presenters, and then they will be back shortly to share with us the outcome of their adjudication, which I'm glad I have absolutely nothing to do with, because I think it's going to be incredibly challenging for them. So with that, I'm going to move on and really just do a brief summary of an issue that was important enough that we considered it should be the white paper for the World Menopause Day for this year. And that was early menopause or premature ovarian insufficiency. I do have some disclosures to share with you. Most of my research is NHMRC or nationally funded, but I have honoraria from consultancies with various components of industry, none of which I believe has anything to do with the presentation I've given today. So I think it's important to consider that premature ovarian insufficiency is not actually normal menopause. It's not the normal age of menopause, and therefore it is actually a pathological condition that merits assessment and treatment. You all know it's loss of ovarian function before the age of 40 years. It can be temporary, periodic, with residual ovarian follicular activity. About 1 in 1,000 women will go through ovarian insufficiency before the age of 30. And we know that the old estimates suggest 1% of women before the age of 40. This has now been revised to looking more like 3.7%, particularly if we include all the iatrogenic causes. And there are multiple causes of premature ovarian insufficiency that you know about. But in fact, the majority are what we call idiopathic, where a cause is not clearly identified. And 1 in 3 women with idiopathic premature ovarian insufficiency will have an affected family member. So there'll be a family history there, but you won't be able to get a specific diagnosis. And that really accounts for about 60% of women that we will see. About 10% of women will have autoimmune disease, and that will be identified by concurrent hypothyroidism, adrenal insufficiency, and diabetes, or a strong family history. So having a first-degree relative with premature ovarian insufficiency increases a woman's risk 6 to 12-fold. So it's a very important point to take when you're taking a history of women, of menstrual history and family history of women. When we talk about genetics, the genes of interest are X chromosome, chromosome 9, and chromosome 8. And it's often not recognized that BRCA1 and 2 mutation carriers on average will actually go through an earlier menopause if they don't have a bilateral risk-reducing oophorectomy. Oh. X chromosome abnormalities are seen in over 40% of women with primary amenorrhea. So it's absolutely essential that women who undergo primary amenorrhea have a chromosomal analysis done. And the most common ones are listed here, and you're all familiar with these. There is a critical region for normal ovarian function on the X gene that we specifically look at, and I'm going to talk about that a little bit more. The Fragile X syndrome is related to the X chromosome, and it is one of the most common causes of cognitive impairment if a woman has an abnormality on the X chromosome in this unstable CGG repeat region. So people who have Fragile X syndrome have more than 200 repeats of the CGG region on the X chromosome, which makes the X chromosome look abnormal. And you get this damaged dangling thread here on the X chromosome. Having 70 to 74 repeats is normal. There's a gray zone. And people who have between 55 and 200 repeats are considered to have a premutation. And a premutation expands with subsequent generations. 1 in 4,000 men and 1 in 6,000 to 8,000 women worldwide will have the Fragile X mutation. The premutation, the 55 to 200 repeats, explains up to 13% of familial cases of POI and 3% of sporadic cases of POI. So it's really important to screen for this mutation. Conversely, of known X premutation carriers, 20% of women will actually develop POI. So if it's known in a family, it's important to recognize that 20% of the female carriers are likely to get POI. You would expect that the risk of POI would increase with the number of CGG repeats, but in fact, there's what we call an inverted U, and the greatest risk of POI appears to be in women with between 65 and 90 repeats. Also, paternally inherited premutations are more likely to give rise to premature ovarian insufficiency than maternally inherited premutations. And again, I emphasize this is a screening test that should be performed as part of the assessment of all women with POI. After cancer, amenorrhea affects about a third of women treated with chemotherapy. And I've listed here the treatments that result in the greatest risk. Although older women are more likely to be affected, about a third of women under the age of 35 years will develop persistent amenorrhea and hence premature ovarian insufficiency. About 30% of patients are amenorrheic 1 year post-chemotherapy. And finally, the other factors we need to consider are the epigenetic effects that include socioeconomic and nutritional effects, lifestyle effects. So there's a lot of talk about epigenetic effects, but what is that? Well, we know that there are other factors that will affect DNA function. It's not just the DNA mutation that we're considering, but if one gets methylation of DNA, one will have changes into the functional activity of the DNA. And things that will alter DNA methylation or increase DNA methylation are aging. We know that nutritional factors, environmental factors, endocrine disrupting chemicals, smoking, other toxins will alter DNA methylation and may increase DNA methylation, and this will alter gene function. And this can be handed down through generations. So a woman who had a grandfather who was a 1 pack a day smoker might have changes in her DNA that will actually affect her DNA function. And these things we know can impact ovarian function because of effects on the X chromosome. How do women present? Well, they mostly present with oligoamenorrhea or infertility. Women less commonly present with things like vasomotor symptoms, urogenital atrophy, etc. And unfortunately, because there are other reasons for oligoamenorrhea in this age group, like stress, exercise, weight loss, etc., we know that it can take many years quite often for a woman to be diagnosed. So it's really important, and what the emphasis for the white paper and World Menopause Day this year is for clinicians to have the possibility of ovarian dysfunction in terms of insufficiency at the forefront of their clinical diagnosis or clinical differential diagnosis. With respect to fertility, it's usually considered reversible if at diagnosis FSH is greater than 100. Fertility may be possible if the FSH is less than 40. And in about 10% of women, if they're taking hormone therapy. If women have streak ovaries, there's absolute infertility, and it's important to discuss with your patients egg donation. Apart from infertility, you need to consider the other psychosocial effects, the consequences of sex steroids in terms of risks of chronic disease, particularly bone loss and osteoporosis and fragility, fracture at a young age, increased cardiovascular disease risk, the probability of thyroid disease and diabetes in women with autoimmune disease, and also in women with Turner syndrome, and premature mortality if left untreated. The essential diagnostic test is an FSH and estradiol in at least 2 samples taken 4 to 6 weeks apart. It's important to exclude pregnancy and hyperprolactinemia. AMH is not required to diagnose POI. Karyotype is essential for young women under the age of 30 or primary amenorrhea. All women should have a screen for FMR1 premutation. You should evaluate thyroid function in all women and exclude diabetes and other diseases if Turner syndrome is present, and look at adrenal insufficiency in women suspected of autoimmune disease. An ultrasound is essential for women who go through primary amenorrhea, and bone density is essential in all women. I won't speak to any extent about Turner syndrome, and I've listed here the increased morbidities that are seen in Turner syndrome. A cardiac MRI is ideal in all patients, if not available, at least an echocardiogram to look at the aortic root. It's essential to monitor blood pressure and glucose and undertake audiometry and bone density. Not all people are expert in managing Turner syndrome, and if there is a Turner syndrome clinic in your area, these women are really best managed by multidisciplinary clinics. I've mentioned genetic testing. Women who are short are more likely to have a chromosome defect. It's important to do genetic testing to identify not the risk for the individual, but also of other family members, and if they've had children, their children. I have suggested that AMH is not essential. It's been popularized as a treatment, as a blood test to predict menopause and to diagnose ovarian insufficiency. The problem is that unless you're using a highly sensitive assay, low from very low is not easily detected. And even with a highly sensitive assay, a single measure is not useful because women have completely different trajectories. And this is a study looking at AMH measured in 3 time points in women under 30, 30 to 40, and 40 to 55. And you can see that some women have a very slow trajectory and other women have a rapid trajectory change in their AMH level, even women approaching their late reproductive years and even just prior to menopause. Some women have flat trajectories and sharp trajectories. So at this point, AMH is not considered useful to predict an individual's age at natural menopause unless you have highly sensitive assay and you're able to do repeated measures. Now, we're not going to be doing repeated measures in otherwise well 30 and 40-year-olds, and therefore we would stick with FSH and estradiol. You need to discuss the diagnosis and the implications, patients' concerns and their needs. It's essential to educate women about the need for hormone therapy. A vast number of women take hormone therapy for a while. If they don't have vasomotor symptoms, they will stop the therapy because they don't understand the benefit for them in terms of reducing long-term comorbidities. Turner syndrome women should be referred to a specialized clinic if it's available. And I don't think that there's any disagreement that all women with primary ovarian insufficiency should be treated at least until the average age of natural menopause, which in high-income countries is around the age of 50 to 51. Generally, we would recommend physiological estradiol and progesterone. It's been shown to be more appropriate in terms of cardiovascular risk. And here you can see that compared with the combined oral contraceptive pill that contains ethinyl, estradiol, and norethistron, estradiol and progesterone have more favorable effects on blood pressure. There is data to suggest is that estradiol is more favorable in terms of bone protection than the oral contraceptive pill. And this is comparing estradiol and levonorgestrel with ethinyl estradiol and levonorgestrel as formulations showing no treatment, the pill and the estradiol approach that's oral, suggesting that it has more favorable effects on bone density. We know that not all women will take transdermal or oral estradiol and a progestin, and that in order to get compliance, many young women prefer to be on the combined oral contraceptive pill. They don't want to be different to their friends. They don't want to have a label that they've got early ovarian failure. They don't want to be on HRT. And any therapy is better than no therapy. So if in order to have compliance, you need to prescribe the oral contraceptive pill, then please do so. There are oral contraceptive pills that contain 17-beta estradiol in many countries. So if you have access to these, they're preferable. And I often see women who've been given the pill, but these are women that would still want to get pregnant. So it seems self-evident that you would not prescribe the pill if pregnancy is desired. But please make sure that if you have a conversation with your patient, if they don't want to get pregnant, they should have contraception. And if they do want to get pregnant, they certainly should not have contraception. The recommended doses of hormone therapy and estrogen are much higher than we would normally prescribe in older women. And that often affects compliance. because 2 to 4 milligrams of estradiol daily, or a 100 to 150 microgram patch, that should be microgram, not milligram patch. Many women will have breast fullness, breast sensitivity. They might have fluid retention or bleeding, and they may again not be compliant. So you might end up having to have young women on an estradiol containing pill. Please don't forget sexual health. We know that women with premature ovarian insufficiency have impaired sexual function compared with age-matched controls, mainly pertaining to low desire and low arousal. But we know that even with systemic estrogen therapy, many women will continue to experience lubrication issues and dyspareunia. So please discuss the concurrent use of vaginal estrogen. Low testosterone may contribute to a decline in sexual desire and sensation in affected women, and we know that women with POI have lower androgens than other women. Consider testosterone therapy, but there are no studies where we can say with confidence that testosterone will improve sexual function with POI. But if it is available and if sexual function persists, it is appropriate to be prescribing this in patients with POI. And vaginal estrogen is something that's often forgotten and should be prescribed when indicated. And I'll remind you again that the patients need to understand the importance in terms of cardiovascular protection. This is a meta-analysis showing that women who experience ovarian failure before the age of 45 compared to over the age of 45 are at greater risk of all-cause mortality and cardiovascular disease mortality. And this is abrogated by use of estrogen, has been shown in a range of observational studies. And therefore, you don't want to scare your patients by telling them they're more likely to get heart disease and die if they don't take their hormones. But I think explaining that the hormone therapy goes beyond symptoms is critical. Oocyte donation remains the most successful option for fertility in women with POI. And human ovarian tissue cryopreservation, which is often done in settings where women are going to understand cancer therapy, is available, but it has to be done in an expert center under institutional review board oversight, because often this can lead to future complications in sort of ethics and legal matters if a woman does not choose to use her tissue. So in summary, at least 1% of women are affected. Iatrogenic causes are increasingly common with women surviving cancer treatments. The long-term consequences are familiar to you all. POI has a profound impact on psychosocial well-being and quality of life, and it is important to identify women struggling emotionally with this diagnosis and their partners as well, and refer them for counseling where appropriate. Initiation of MHT should be early, and therefore diagnosis needs to be early. Therefore, you need to be on the lookout for the condition. Don't forget vaginal estrogen, and testosterone supplementation can be considered. So with that, I believe the judges are ready. So I would like them to re-enter our screen and share with us their assessment and their findings for our very wonderful presentations this morning. So I can see Nick has re-entered, so I'm waiting for our other judges to re-enter. And I'm waiting for Tommaso, our chair, to re-enter now, because I have no idea what the judging has been. As you can see, I've been busy chatting to you all. I hand you over to Professor Tommaso Simoncini, and welcome our judges.
Thank you so much, Susan, and I assume you've given your usual wonderful presentation, and I'm so sorry we missed it, but we were fortunate enough to be discussing quite hardly, because it was not an easy decision. So I'd like first to thank Professor Joanne Pinkerton, Professor Rossella Nappi, and Professor Nick Panay for joining this judging committee and to help me in reaching a conclusion. So I think that I'll bring the views of the panel in saying that all the 6 speakers were are absolutely outstanding. As Professor Pinkerton said, that there was really no presentation that was not above the bar. So they were absolutely all awardable presentations. Unfortunately, we have not the possibility to award 6 awards, but we have the possibility to award at least 2. And we decided to award 2 prizes this time, because we really think that there's a need to acknowledge the excellence of these 2 presentations. So we thought, we had a very long discussion, and we weighted both the scientific excellence, the way that the presentations were presented, and we must say that none of the presentation was not, if absolutely outstanding in the way, in the clarity and in the synthesis. So congratulations to all the speakers. And the data quality was absolutely outstanding. Anyhow, so in choosing the 2 winners, we thought that there were 2 presentations that really made us willing to give the award. The first one is a more scientific presentation in terms of basic science investigation into an endocrine original area. And this was the presentation of Dr. Alejandra Martínez García on the normal ranges and determinants of circulating estrogens in all the postmenopausal women. We were impressed by the quality of this data and by the innovation that it brings in considering the types of estrogens that we have to measure. So congratulations to Alejandra, and because it's really well deserved. And then we selected another presentation, which is more clinical, but it's yet very, very original in the way that it's designed. And also it was presented in a very professional way, we thought. And this is the presentation from Kling from the Mayo Clinics on the association of estrone and cognitive performance in recently postmenopausal women with hormone therapy. So we really thought that this presentation was clear, was outstanding in quality, and it really kept us looking at the presentation with a high interest. Having said that, we really regret not having had the possibility to award also the other 4, because this time was really hard. So congratulations to the 2 winners, Alejandra and Jewel. I see you both on the screen now. And I think before giving back the word to Susan Davis to give the last greetings, I would also like to thank the more than 200 participants. It's not usual. So this virtual way to organize things is working quite nicely. I've never seen the Greenblatt Award session at the World Congress of Menopause being assisted by 200 persons. So this was really nice. So thank you all. And Susan, you have the podium again to greet the symposium.
So I just want to thank everybody. I want to thank Tommaso and the judges for the amount of time that's taken to, read the abstracts, even assess the shortlist of candidates was enormous. There were many candidates beyond just U6. There were many, I think there were over 40 original, and Professor Nappi, thank you for Professor Nappi also. But I think if I recall, there were over 40 candidates for this award. It was very difficult to shortlist 6, and I'm sure for the judges, the presentations were outstanding. To adjudicate and choose 2 was very challenging. And so you are all winners. I congratulate the two named winners, Juliana and Alejandra. That's wonderful. And I'll just also conclude by saying this is the last formality over which I preside as the past president now of the International Menopause Society. The president is now Steve Goldstein. And so I look forward to sitting back, relaxing, and enjoying my time as a past president. And again, it really is noteworthy to have over 200 people online, and 150 online until the very end of this session is really an acknowledgement of the importance of this and the support of our young researchers. So thank you all. Good evening and good morning to you across the world. And thank you, everybody.
Congratulations, everyone. Well done.
Well done.
Great presentation.
Thank you so much.
Of menopause research to have such great proposals and presenters. I'm so excited for the future of menopause.
Superb standards. Keep them up.
I just want to thank you so much for this award, and I would like to thank also the IMS especially, and Professor Susan Davis also, that had me here for a year in a pandemic situation. And without her support and all the staff at a Women's Health Program, I couldn't have done it. So thank you so much for your help and your support.
And I also echo the appreciation. You all here are the giants of menopause and have led the way, and what a privilege to share a Zoom window with you. I look forward to seeing you in person in Lisbon, hopefully in a couple of years. So thank you.
Thank
We're
you.
all hoping.
Thank you
very
so
much.
much, Jewel, and I think you gave us the good hint to announce the next webinar, and which is coming on the screen. So thank you so much. And on November 10, we will have the next webinar organized by IMS, and it's going to be incredibly interesting on managing menopausal bleeding with two outstanding speakers. Steve Goldstein, our president now since Sunday. So it's going to start in full speed with this webinar, and Denise Black as well, moderated by Mara Shapiro. And as Jewel said, then we need to be optimistic enough to say that in a couple of years we will see all in person in Lisbon, hopefully, with no COVID at all. So thank you so much for joining, and it was a real pleasure for me. Bye-bye, you all.